Kind of a cool thing that I didn't know until this morning is the Healthcare Advocate Summit team has been able to get this approved for a prior authorized certified specialist CE credit. So kudos to them for doing that. So your time here will hopefully be informative, but also well spent from that perspective. Okay. So what I'm going to do is I'm going to just talk about the common cost sharing tactics by PBMs and payers. Going to get then specifically into copay adjustments, accumulators, and maximizers, and then we're going to talk about implications and what it all kind of really means. The first section is going to be review, I think, for just about everybody, so I won't dwell on it. But you know that manufacturers like Daiichi Sankyo and others often will have programs to help offset what can be very high cost shares for patients. And I say cost share to sort of put copay or coinsurance in the same bucket, right? So I say cost share, it means those two things, or it could mean deductible as well. It does mean deductible as well. It can be a pretty large financial burden, especially for an expensive oncologic medication, or even if it's not a medication and you have multiple other not quite so expensive, quote unquote, it can all add up, right? So these cost shares can be a pretty big financial burden. And so manufacturers put these programs in place to help patients. They often will reduce or sometimes eliminate. And when I say reduce or eliminate, what I mean is sort of what that looks like is the programs can pick up all of the cost share to the last dollar, or more often they'll pay like anything after the first $25 or $50. So if somebody is enrolled in the program and they have a $200 coinsurance, the manufacturer might pick up the first 25. The patient would pick up the first 25 and the manufacturer would pick up the rest. So they can be varied a little bit, but typically it's all or most all of the cost share. And so this is the part I'm going to go through kind of quickly, but stop me if anybody wants me to slow down. So the deductible is basically the phase of insurance that exists before the insurance kicks in. So the patient is on the hook for whatever costs fall under that deductible. There are some services, some preventive services, checkups, certain immunizations that are outside the deductible. You get them for free no matter what as part of the ACA. But in this example, if there was a cost, and this is drug, but it could be a procedure, test, office visit, whatever, that was $100 and the patient hasn't met their deductible, the patient would pay that entire cost, right? It's the amount before the insurance really kicks in. That's the deductible. A copay is a fixed amount. So no matter what the service, drug costs, it's going to be the same. So if it's a $20 copay and the medical visit or the drug, whatever, is $100, it's patient's going to pay $20. If that same thing or a different thing would cost $200, well, the copay of $20, it's still $20 because it's a fixed amount. Makes sense, right? And that doesn't start till after the deductible. Coinsurance, however, is a percentage of the allowed amount. So once the deductible has been met, if the total cost of the drug or service, procedure, what have you, is $100, the patient would pay 20% in this example. Could be 30%, could be 10%. But in this example, it's 20%. The patient would pay $20. If it was a $200 cost, who wants to do the quick math and tell me what the coinsurance of 20% on 200 would be? Exactly. You got it. So coinsurance, copay, deductible. Out-of-pocket max. I may take a second on this one because this is kind of an important and sometimes misunderstood piece. So just about every type of insurance has an out-of-pocket maximum. Now, I don't know if some people at least were probably in the triage cancer presentation before lunch, which was awesome. Know those people, they're great. And she talked a little bit about this. There are some exclusions like grandfathered health plans, which there's very few. Those are plans that were in existence before 2010 when the ACA was enacted and haven't changed substantially since then. That's 13 years ago now, so as you can imagine, there's not many left. Short-term health plans, association of health plans, church, the very niche kinds of plans, they're not bound by this, but just about every other kind of plan, and probably 99% of people in this country are in the type of insurance that has an out-of-pocket maximum. Even a self-funded employer, self-insured employer, to which many federal regulations do not apply, still are bound by this. They have an out-of-pocket max. Important point here is that the out-of-pocket maximum for this year for an individual is $9,100 for an individual, and then for a family it's $18,002. As of 2016, the individual out-of-pocket maximum became embedded, that's CMS's term, not mine, with the family out-of-pocket maximum. The significance of that is if I've got a family of 4 and my out-of-pocket max for the family is $18,002 and the individual's $9,100, and I'm the sick one, and I incur healthcare costs where my cost share would be $10,000, I'm only going to pay the $9,100, even though the family out-of-pocket max is $18,002. Before 2016, that was not the case. And I hear this talked about sometimes, and that's a nuance that kind of sometimes gets missed, but it's a really important one. So I guess the exception to that would be that if you're in a plan that has and that's the most, right? They're often lower than that, right? I think my family, my wife's a teacher, we have insurance through her. I think our out-of-pocket max is like $4,000. So in a case where like me, if it's a $4,000 individual, and I'm making it up, I don't remember, $6,000 family, I would still have to pay the $6,000 family because it hasn't met this maximum amount, right? But important numbers to keep in mind. Accumulators, maximizers aside, those are kind of good. The embedded concept is a really important concept. And so that out-of-pocket maximum applies to covered in-network benefits during that year. Some plans will have an out-of-pocket max for out-of-network. They don't have to, but some of them will, some of them won't. But this one you can sort of take to the bank, right? Whether they choose to have an out-of-pocket max for out-of-network or not, that's cool. If they do, it's nice, but they don't have to. They can, if it's out-of-network, they can simply refuse to cover it. So in-network, out-of-pocket, in-network covered essential health benefits. And what's included, deductible, copayment, coinsurance on in-network. The premium is not covered. That's the cost that you pay every month to buy the insurance, you and or your employer if you're employed and your employer is sponsoring it. Anything the plan doesn't cover, cosmetic procedures, non-medical, experimental, investigational, and out-of-network, and the cost that above and beyond the allowed amount, which would really apply to out-of-network, is if somebody's in-network, they've agreed to accept that payer's fee schedule, right? All right, now for the fun part. So the accumulator, and I remember where I was when I heard this for the first time. It was probably 5 or 6 years ago, and it was an old colleague from J&J. I was in my office, and I don't know, he probably just called me to catch up, and he's like, oh, so have you heard about this accumulator? I'm like, huh, what are you talking about? And my head exploded. I'm like, how can they do that? Doesn't seem right. And the technology piece of it was answered fairly quickly, but it was just like this new, like, wow, they've figured out a new way to, to scrape money from somewhere. It's amazing. And so basically, the way the accumulator works, and this particularly is applicable to pharmacy benefit drugs. It's very difficult, if not impossible, for a payer to do it on the medical side, simply because of the way it all works. And the easy non-tech guy way to describe it is if you go to the pharmacy and you give them a prescription for a drug, the pharmacist takes your member ID, and in 30 seconds they can tell you, is the drug covered? Is there a prior auth? Communicates with all the payers. And so there's a visibility and a line of communication there that doesn't exist under the medical benefit, where the payment's really between you and your doctor. And so payers are just really trying to figure out how to do this on the medical benefit side. And a couple of years ago, one of them, which I think I remember which one, but I don't want to say it in case I'm wrong, tried to, he knows, I don't want to throw him under the bus, or maybe I do, but I won't. They tried to roll out something where they were going to sort of push this maximizer, but the doctors had to report it. So they had to manually tell the payer, yeah, this patient paid me their coinsurance, but it was really the manufacturer's funds. And there was so much pushback that they dropped it. But they haven't figured out a way to do it yet, as they can do it effortlessly under the pharmacy benefit. So stay tuned. That's going to change. I've got to think. I couldn't tell you how it's going to change. If I had the solution, I'd like to say I'd keep it secret, but I'd probably make so much money by telling the payers, I'd do it. But that's, I've got to think they're going to figure out a way, right? So with the accumulator, you go to the pharmacy, they adjudicate that script, they tell you your copay or coinsurance is X amount of money. They have that debit card or that number, maybe a physical card, maybe it's a pamphlet that the pharmaceutical company gave the patient, whatever. They run that through, the pharmacy gets that money. And because if you pull out your credit card, there's series of numbers, right? There's like 3 or 4 sets of numbers. And those numbers identify who the payer is. There's a bin number, which I used to know what bin meant. There's a PCI, and there's those components flag the source of those funds. That's how they know it comes from the manufacturer. And that's the component which doesn't exist on the medical benefit side. So the payer automatically knows where that money's coming from, and their system sort of sets it aside and does not allow it to count towards the patient's out-of-pocket expenditures. That's an accumulator. So they'll take the manufacturer's money, and let's say the manufacturer, for any particular drug, different manufacturers have different program limits, right? So let's say it's drug X made by company Y. That company Y will say, okay, we're going to have this support program in place, and the maximum benefit is $20,000 a year. That's pretty common, something around that amount of money, right? And so they'll pay all the patient's cost share up to that $20,000. The money's depleted. Now the patient's on the hook. They're back to square one. They've got to pay their deductible and all their other cost shares. So the insurance company is taking the money from the manufacturer, not counting it towards the patient's cost share until it's gone. And then they say, okay, now you got to start paying us. I'll talk about that a little bit more, but you can imagine this sort of shock, right? Because if I'm the patient, I've been going to the pharmacy all year, I'm like, this is great. I don't have to pay a dime. My friends are telling me this drug's expensive. They're crazy. They don't know what they're talking about. And then come June, they say, okay, that'll be $5,000, Mr. Woody. And I go, what? Where'd that come from? Because the patients don't know. The plans are supposed to tell them, I'll get you in just a sec. The plans are supposed to tell them that these things are in place. Often they don't. Often when they are published on the plan's website or in their explanation, gosh, I don't remember what it's called, but the book that describes all the benefits, it's buried in the back in fine print, and it's called something different. They call them all sorts of tricky, fun names, which I have on a later slide. So patients are almost all the time completely unaware. And so it can be quite a surprise. Catherine. Yep. Yeah. That's a question I've asked myself many times, right, Chad? Yeah. Yeah. So I don't know if everybody heard that question, but I'll say it again because this drives me bonkers, right? Because I work for a pharma company. So we have a drug that's a $26,000 annual program benefit. Well, if you know that the out-of-pocket maximum is $9,100, why would you ever make your program benefit greater than $9,100? And the answer is, well, that's the way we've always done it. Sorry, but I think that's the truth. But we're rethinking that because what's happening is we're paying an extra $17,000 more than we kind of really need to when these things are in place. The other side of that coin is we're in oncology, and most oncology drugs, well, I shouldn't say most, but a lot of them are infusible medical benefit, so they kind of can't catch us on that. But even the oral or the pharmacy benefit drugs, they don't, more and more they're applying these to oral oncolytics, but historically they haven't really done it. So we've kind of lived outside in our own little bubble, frankly, up until this point. But that's changing, and at some point we've got to rethink that because we're just giving money away we don't have to give. Yep.
Maybe early, but how do they do? What do they do with the alternative funding sources on this? Do they apply them as well?
Can I stick a pin in that? And if I don't get to it, all right, because because I know people do want to talk about alternative funding, and I want to as well. I'll stay with the flow a little bit. Mm-hmm.
So essentially, the PBM or the manufacturer's offsetting costs for the consumer at the pharmacy. PBM is rebating the insurer on the other side.
Well, maybe. It depends. Boy, and maybe that'll be next year's talk, actually, is the PBM payer relationship. There's two ways PBMs are paid, fee and spread pricing. The fee is the payer just gives them a fee, right? You adjudicated $1 million, we're going to give you 2% of that. Or you can keep the spread between the rebates you're getting, what we're paying you, and sometimes they give part of the spread back. It's a morass of confusion and I almost said deception, but that would be wrong of me, wouldn't it? It's a complexity, shall we say. It's a complexity. So I'm going to give you a fun math example because we all love math. Said I was married to a math teacher earlier, I think, or maybe just a teacher, but she had to help me understand all this stuff. I'm not going to go through all the, unless you want me to, I'd be happy to. But at the top, you see what the assumptions are. It's a coinsurance of 30%. The patient's got a $3,000 deductible, an out-of-pocket max of $6,000. Because remember, I said $9,100 earlier, but that's the most it can be. A lot of plans, I think, most I'm pretty safe in saying have less than that. So when you say 9,100 or when I say 9,100, I'm talking the worst case scenario. A lot of them are a lot less. In this scenario, it's $6,000. The copay card patient requirement is $25. So even though the manufacturer is going to pick up the bulk of it, the patient still got to pay $25. The manufacturer will pick up the rest. Drugs, $3,000 a month, and the program is funded to a limit of $15,000 a year. So those are the assumptions. And this is a traditional scenario where there's no accumulator and no maximizer. And this is great because what you see is month one, the patient's got a $3,000 deductible, right? The patient pays their $25. The manufacturer is going to pick up the remainder of the deductible, which is $3,000 total, so $2,975. The plan pays nothing because the drug costs $3,000. So it just happens to work out that way, right? The next month, deductible is paid. Now the patient has to pay 30% coinsurance. 30% of $3,000 is $900, but they've got a manufacturer copay program. So the patient pays their $25 again. Manufacturer picks up $875. 30% is satisfied. Now the plan's kicking in. And because the plan is counting all of this towards the patient's out-of-pocket, come May, they've paid their out-of-pocket max of, what was it, $6,000, right? June, they have nothing else to pay. It's great. That's the way manufacturers want it to work. That's why they put all this money into this little special fund to the side, is because we know that the more patients have to pay out of pocket, and right, I say patients like I'm not one, right? We've all been to the doctor. I'm a patient. I don't like to pay money either. So at some point you go, you go, I can't afford that, so I'm out. Some of us go, well, I can't afford that, but gosh, I really don't want to. And then you go, well, I really don't want to, but I have to, I'm going to die, and hopefully you can, right? But there's sort of that continuum. And so that's why manufacturers do this. There's probably a lot of reasons, to be honest, but that's sort of the spirit of this is we know financial toxicity is a real thing. And so we set this money aside, and this is the way we want it to work. With an accumulator, which is what we are going to look at next, and then we'll get into maximizers, it works quite different. Whoops, I think I went 2 slides ahead. Okay, here we go. So here's the accumulator. What you see, first couple months, well, the first month looks the same, right here. 25, 29.75. The second month is where you see something a little screwy going on. This is different. Because in the traditional scenario, this was $875 because the deductible had been met and the patient was now doing the 30% coinsurance. Because they didn't credit, because the payer or PBM did not credit this towards the patient's out-of-pocket max, it's like they paid nothing. They're crediting the $25, but not the rest. And so you see that continue. Every month it's deductible, 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 deductible. Now the manufacturer's money's gone. Okay, Mr. Woody, you owe us $2,875. And I never knew that was coming. The odds that I saw that coming are 1 in a million. Because the plan never told me. More importantly, I probably never went to look for it. And if I was one of the few rare people who did look for it, the chances of me finding it are like a 4-leaf clover. So come June, I've got a decision to make. Can I afford this? Do I want to afford it? If I don't afford it, what's going to happen to me? And that's not what the manufacturer wanted to have happen. But I'm going to put on my plan hat for a moment, much as it pains me. If you're an insurer, if you're an insurer or the employer, you can only set premiums on 4 things. Now, this is not the way it always was. Before the ACA was put in place, you could deny people coverage for pre-existing conditions. You could charge them more for pre-existing conditions. You do all sorts of stuff. You could say your maximum benefit a year is $50,000. If your healthcare costs more than that, you're out of luck. Age, family size, smoking status, and geographic region of the country in which you live. So if I'm the payer and I'm handcuffed, right? And by the way, my premium for the most expensive age bracket or group of people can only be 3 times greater than that for the least expensive. So my ability to price and generate revenue and offset my healthcare costs, which I hope I have the right actuaries. I hope my actuaries are good because they're going to predict what my cost should be next year based on my panel of patients. If they're wrong, I'm out of business, right? And my ability to offset that is very, very limited. So so if I can now find an alternate source of funding to offset my costs, I don't blame them for doing it. I hate to say it, I get it. For the patient, it's not cool. But I see why the plans do it because they're very, very limited in their ability to offset their costs vis-a-vis different premium changes. So you can hate me for that, but that's okay. Just trying to be objective about it. So there's the accumulator. Any questions? Did it make sense? Fun with math, right? All right. So the net of all this is the traditional scenario here shows what the patient would have paid, what the plan sponsor would have paid, what the manufacturer would have paid. And I apologize. I know I keep moving this microphone back and forth. And then under the accumulator, what the difference is. Everybody takes a hit except for the plan sponsor does pretty well. That should be negative 15,000, by the way, on the plan sponsor on the far right. That's my fault. I need to get an assistant to help me type. So the patient and the manufacturer are paying a lot more, right? Plan's not. Again, they would say, well, I need the money or I'm going to go out of business because my actuaries were a little off this year and I can only bring in revenue within a very limited bandwidth. So that's why they do it. All right. So maximizer, I look at it as sort of the more gentle way of doing it, perhaps. The way, and I'm not going to look at the slide, but tell me if hopefully I won't disagree with what's up there. The way the maximizer works is basically the plan or PBM takes the manufacturer's annual program limit, let's say it's $12,000, and they divide it evenly throughout the year. They then make the patient's cost share that amount. And the way they're able to do it is because they deem the drug a non-essential health benefit. These are typically self-insured employers where a lot of the regulations don't apply, right? So they can just call it, it's a non-essential health benefit. We'll still cover it, but we're going to cover it different. So your cost share, Mr. Woody, on this type of drug is a 20% coinsurance, but for this particular one, because we know there's a maximizer in place, and we know the manufacturer has a $12,000 annual limit for the program, it's going to be $1,000 a month, and you don't have to pay any of it. So you don't, and I'll go ahead, I guess. As a patient, you don't get that, June, July surprise of like, now you owe me $3,000 because I'm just paying my $25 every month. Cool, love it. As a patient, works for me. Manufacturer still gets bled of all the program money. And the plan sponsor doesn't make quite as much back. I'll show that on the next slide. I guess I'm getting ahead a little bit. But the reason the plan sponsor doesn't get quite as much is because they're not putting that patient back to square one after the funds are used up after a few months and then getting the deductible and the normal cost shares from the patient. So that's sort of how the math works. It's sort of the middle ground between traditional and accumulator. And it all hinges on the ability of the plan to deem it a non-essential health benefit, which allows them to make their own special cost share for that drug, which my mind blew up when I heard about that too. Like, how do they do that? But that's how. And so traditional versus a maximizer scenario, it's higher for the patient, but it's $175 spread throughout the year. Maybe not that big of a deal. The manufacturer still loses their entire allotment of $15,000. It could be $30,000, whatever. They're gonna. I mean, if it was $24,000, the plan would make the patient's cost share $2,000 a month. If it was $36,000, they'd make it $3,000 a month. They're gonna max it out, right? And the plan sponsor is not as well off as if they had an accumulator, but they're a lot better off than the traditional scenario. And as I sort of opened up, I think I'm doing, oh yes, comment or question? Mm-hmm. Yep. Yeah. Oh, thank you. I'm glad I should have said this. I don't know if I said it at all, let alone more clearly, is that because with the maximizer, they're still not applying anything other than the patient's $25 in that scenario. It could be 50, could be nothing, whatever. They're still not applying it versus to the patient's out-of-pocket spend. So it doesn't impact the deductible. The $25 counts towards their deductible, but nothing that the manufacturer kicks in does. Did I answer that? Is that where you're going? Okay. Yep. Yeah, that's good. I'm glad you said that. I don't know who was first. Sorry. Yeah, I chuckle because like the math behind this stuff can get pretty complex, but they can't figure that out. Like, come on. 28 days supply. By 12. Yeah. Yeah. Thank you for that. That's great. I mean, it's not great, but it's a good insight. Was there another? Sorry. Yes.
The maximizer is allowed because that's deemed
Yeah, the payer deems it a non-essential health benefit.
it's a prescription drug benefit.
Yep. Yeah. Yes, they are. So good. I love it. This is great. So yes, so there's 10 essential health benefits. Let's see, you're giving me, I get next year's talk and the one after that now too, because of these ideas coming. Yeah. So prescription drugs are one of the 10 essential health benefits. However, in a particular state, don't pick one of your choosing. So I'm trying to think how to. So drugs are an essential health benefit, but that doesn't mean that plans have to cover every drug that exists, right? And so the nuance there is they have to cover one drug in every U.S. pharmacopoeia listed category, or they can choose to cover drugs the way the benchmark plan of their state covers them. That's the out. That's a great clarifier, though. Thank you. So that's how they get around that, right? Because drugs are an essential health benefit, but it's one from each U.S. pharmacopoeia listed category or consistent with the benchmark plan.
And this stuff only applies to like commercial insurance or individual plans. It's not Medicare in any way, right?
Correct. Not med. Yeah. Thank you. Yep. Yeah. Yeah. And that's another point that's not on the slide deck. But as manufacturers, we can't deploy our copay support to any government plan like a Medicare. I mean, Medicaid, you really kind of wouldn't need to anyway. But you can't do it for that. It's all commercial stuff. So yeah. Yep. I know. It's like the legalities of this are just mind-boggling, aren't they? Yeah. It's like, well, whatever. I have all sorts of. We'll hang out later. We'll talk. So accumulators and maximizers are becoming more, I would not say popular, but prominent. It's more commonplace. And maximizers a little bit more so. You see from 2020 to 2021, they jumped like from 23% of lives to 45%. And the accumulators, which are on the left, was, nudged up just a little. I think it's because plans probably have caught so much heat. Maybe they're like, we don't want to look that evil, so we're going to maybe take the middle ground. But you've got to think these percentages are just going to keep going up, right? Mm-hmm.
So when you do a benefits investigation, can you find that out if they have a maximizer?
You should be able to. They're supposed to tell you. Whether the person with the headset and the script is going to know, we'll put money in a jar and split it up next year.
One suggestion is in your call guide, Q&A, whatever, incorporate that question into your questions to the payer.
That's great advice. Get them used to answering it.
Because it would be great to be able to prep the patient.
Yep.
Right, when I'm taking the summary benefits back to them to be able to prep them to say, hey, this is what this will look like.
Yeah, I mean, they're supposed to tell them, but we all know how that goes. So I think asking the questions are great. I'd be surprised if the ones that have one told you on a regular basis, but I think the more we ask them and the more they're called out on it, the more they'll realize they have to tell you. Yes, sir.
Are we just talking about employer-sponsored plans? We're not talking about, they're not doing this, are they?
They could. The maximizer is more common to the self-insured or self-funded employers, but yeah, any commercial plan can do this. Yeah. Yep. Yeah, accumulators. Yep. Accumulators and maximizers the maximizers are more so to the self-insured, self-funded, but the accumulators, if it's a commercial plan, they can all do it.
So feel free to say we're not going down that rabbit hole.
Okay. You're tempting me. It's hard for me to do that.
So some of the biologics, they can be either a pharmaceutical benefit or a medical benefit.
That's right.
So
Yep. Yeah. So, I love this rabbit hole though. I'm going to answer this and then I'm going to move on and then we'll catch some more at the end if time allows. And especially in the world of oncology, well, I keep wanting to say most, but a lot of the drugs are infusible, medical benefit drugs. But payers can cover them under pharmacy if they want. And here's the reason to do it. One of the reasons to do it. I mean, there's many, but one of them is if I'm a payer and I've had a taste of this and it tastes good and I want more, well, I can just switch, the traditional medical benefit to pharmacy. And now, thank you to all the manufacturers for helping me to meet my numbers this quarter. You're totally right. Yep. And in practicality, doesn't look any different to the patient, right? It's just behind the scenes stuff.
Have you seen that trend though? I haven't seen it yet, but I feel like it's coming down the pipe.
Yeah, I'm with you. I would say the same thing you just said. I haven't seen it, and I'm not aware of it, but it's hard to think that it would not be a temptation that could be resisted for long. All right, I'm going to move. I don't think I have that many more, so I'm going to cruise through them, and then we'll do some questions. So here's the difference between accumulator and maximizer. Maximizer much better for the patient, as we've been sort of talking about. Plan sponsor, accumulator is the best, but do they want to be that mean about it? Sometimes they do. Sometimes they'll do a maximizer. And for the manufacturer, we're getting dinged either way. It doesn't, we don't like either one of them. So, you guys, know this slide better than I do, right? People are paying more and more out of pocket. And again, to be fair to the insurers, well, especially drug costs are going up. All sorts of other costs are going up. You had this whole COVID, pandemic that came out of nowhere that hit insurers hard. So they got to get the money from somewhere. They have to stay in business. That's their side of the story. Here are some of the funky names. We were talking a minute ago about if you ask them, will they tell you? I don't know. If they do, they go, oh no, we don't have an accumulator. We have a coupon adjustment benefit protection plan. Sounds good, right? So that's not an accumulator. No, we'd never do that. Okay, implications. Let's see. ASCO, it's the American Society of Clinical Oncology. Told you we were in oncology, so but I bet you any society would mirror this sentiment, right? They don't like it because they realize the impact to patients is negative. The higher out-of-pocket goes, the lower compliance goes, and the lower compliance goes, the worse outcomes are. So if you're a provider, you can't like this. And I know nobody in this room likes it. And we got something about a year ago with my wife's insurance through the school where it was a maximizer, and we had to sign up. And basically the letter said, you don't have to sign up for this, but if you don't, your drugs won't be covered. If you have a drug on this list, you can sign up and you'll have a minimal out-of-pocket cost, but we're not going to tell you have to. It won't be covered. So that's the way that looks in the real world when it comes through with the maximizer. Mm-hmm.
You already can't use a copay card or program with CMS plans, so why do they need to?
Yeah, they still have oversight because there's like federal regulations that govern, plans, and so they would just administer that piece. Yeah, no, but it's a great, because it makes it sound like Medicare. Yeah, yep. Oh, okay, and this is a biggie too. So federal and state governments, ASCO recommends that they should pass legislation, and I think I'm getting one slide ahead of myself, and I'm going to do it anyway. Is there are a number of states that have passed legislation forbidding. Okay, good. Forbidding accumulators and maximizers, which is great. What did I say? It's 19 states. I thought it was more than that, so it's 19. Great thing, right? Keep in mind, that does not apply to ERISA regulated plans, which are regulated by the federal government. And when I say ERISA, we know about 50% of lives or people in this country have health insurance through their employer. We furthermore know that somewhere between 50 and 60% of those insurers are self-funded or self-insured. So you're talking, excuse my rough math, somewhere between 25 and 30% of people, even in these states that forbid the use, the ban doesn't affect them. They still are hit with these things.
And that use of this is a common misperception.
Yes, absolutely. Yep.
We want to drive legislation the right way, but don't be misinformed that if you're one of 19 states, there's still some limitations.
Yeah, you're not out of the woods. You're the people with whom you work and who you support. And I'll say thank you as a complete side note, thank you for what you do. We've all probably known people and had people in our families, with serious health conditions, and it's scary and they don't know what to do and they're confused as heck. And you guys are the beacon of light to them to help them try to make sense of this. So I applaud you. Before I end, I want to make sure I acknowledge the work that you do. It's super important. Wait just a second. I'll get to a question. Let's see. Summary, these things are bad. Okay. Yes. Well, I think I'm done, but thanks for coming here and listening. I hope it was informative and good, and hopefully see you next year. Thanks so much.